How is electronic health information used in the move from fee-for-service to fee-for-value reimbursement models?
Great question, and so the answer is it's fundamental in order to make that transition. If you don't have data to measure quality, you really can't show that you're providing quality care. Physicians are going to be reimbursed based on outcomes and based on the quality that they can display. Their ability to pull those reports together and to demonstrate the fact that they've not only provided the care, but they've provided it in a way where the patient outcome has improved to a certain degree. They're going to get paid more for the number of positive outcomes they have, not just the number of stuff that they do. So it's instrumental in making that happen. Now, we know it's not easy. As a IT guy and having worked in hospitals all my career, in fact, I was born in a hospital, I understand how difficult this is. We don't do a good job in healthcare of connecting dots. As Laura said earlier, interoperability is where we need to be, but it's not where we are just yet. Recently, I had an experience where I went online to Amazon to look for something for my daughter to track miles as she jogs. Within seconds, I wound up on Facebook. I'm kind of old school with social media, so I went onto Facebook, and there was an advertisement for the thing I had just looked at. Other industries are using data and analytics in ways that healthcare needs to catch up on. In healthcare, we don't do a good job keeping track of patients. We're always doing this, roll the dice and let's see if we can do demographic matching to make sure that the patient who lives at this address with this phone number is the same patient who showed up in this setting of care. We've got to get better than that. One of the things I'm interested in working with the New Jersey Innovation Institute and as the executive director of the New Jersey HIN, we're putting together some foundational aspects of where healthcare needs to be, including a master person index, so everybody in New Jersey who's receiving healthcare gets an identifiable number. That's almost blasphemy now. Nobody wants to talk about putting numbers with people anymore, but trying to make healthcare work in a way where you always do this fuzzy matching is really taking us down the wrong path. We also need to do real-time notifications. As Doug indicated, this notion of let's figure out what hadn't gone right over the course of the last few months, and next time maybe we'll get it better. No, we need to understand what's going on with a patient at a setting of care by getting real-time notifications to the right place at the right time. So as we set up the ability to do ADT notifications, which is really basic stuff, there's companies out there like Patient Ping who are doing this all the time. The first thing doctors will tell you is, yeah, send me notifications. I'd love to know every time one of my patients ends up in an inpatient setting or an emergency room. And then as soon as you turn that on and they start getting bombarded with those messages, the next thing they say is, turn it off, you're overwhelming me. I really don't care that every one of my patients is being admitted someplace. I do care about those high-risk patients, as Laura said, and as Doug said. We need to continue to do risk stratification, understand where those highest cost patients are in the curriculum. Those are the patients the doctor wants to know just wound up in the emergency department, because that way they can get involved and start to drive better care from the moment they have that notification. There's a lot of things that need to occur. We're very excited. New Jersey's at the point where the New Jersey Health Information Network is taking the next steps. We've done a pilot to show proof of concept on these capabilities over the last 2 years. And just in August, we moved from pilot to going statewide live. Laura and I have worked together with a group called SHEIK, which is Strategic Health Information Initiative, which is a nationwide kind of collaborative around HIEs across the country. We kind of understand what is good about the HIE model and what needs a lot of work and a lot of help. There's great assets in New Jersey. There's HIEs that are standing up that are connecting 6 million plus patients. What we need to do at the state level is not reinvent wheels, but connect the dots between the HIEs that are out there and functioning with the providers, with the payers, and get all that information flowing in the right direction. So I'm sorry, that was a long answer to a short question.
It's exciting stuff. Thank you very much.